Good morning.
Good morning, Doctor.
Okay. So today, welcome to the first series of the cardiology update lectures. Today, I will be talking on pregnancy and heart disease. As you know, pregnancy, heart disease is becoming the most common cause of maternal mortality. And in the US, cardiac disease complicates 1 to 4% of pregnancies. And pregnancy is, in most women with heart disease has a favorable outcome, both for mother and fetal outcomes, with some exceptions like Eisenmenger syndrome, pulmonary vascular obstructive diseases, Marfan syndrome with dilated aortic root, where maternal mortality can reach up to 50%. But in the remaining majority of patients, in 75% of the pregnant cardiac patients, outcome is favorable. However, pregnancy can be complicated with heart failure, arrhythmia, and there could be development of pregnancy-related cardiac complications like cardiomyopathy, pregnancy-induced hypertension, and so on. So we need to focus on management of cardiac disease during pregnancy. If you see the data from the UK, as you see, cardiac disease is the most common cause of indirect cause of maternal mortality. So it is a significant cause of maternal mortality in the US and also in developing countries. When we see the etiologies of cardiac disease in pregnancy, in the West, as you see, hypertensive heart disease, hypertensive disorders are the most frequent cardiovascular events during pregnancy, accounting for 6 to 8% of all pregnancies. But among the heart diseases in the Western world, as we see, congenital heart disease is the most common cause of cardiac disease during pregnancy, accounting for 70 to 80% of the cases, and with shunt lesions predominating, whereas in developing countries like ours, still rheumatic heart disease predominates, and it accounts for 56 to 89% of the cases. And even in the US, excluding hypertensive disorders, still cardiac diseases account for 25% of mortality, maternal mortalities. So it is one of the most common cause of mortality as to the data from the Western countries. So knowledge on physiologic changes during normal pregnancy is important to interpret the hemodynamic and cardiovascular tests in normal pregnancy, and also to know the impact of these physiologic changes in those patients with pre-existing cardiovascular diseases. So because of this, let's see some of the changes. So as you see, as early as the 5th weeks of pregnancy, cardiac output starts to increase progressively and reach a plateau in the second trimester of pregnancy, and it reached about 45% increase in the 24th week of pregnancy, and similarly, stroke volume tends to increase during the same period. Heart rate increases by 10 to 20%, that is 10 to 20 beats per minute, starting from the first trimester of pregnancy. And as you clearly see, stroke volume increases progressively from the 6th week of pregnancy progressively, and it doubles by the second trimester of pregnancy. So there is a progressive increase in cardiac output, heart rate, and stroke volume, beginning in the first trimester and plateauing in the second trimester. And systemic vascular resistance also decreases progressively. As we see, systemic vascular resistance begins to decrease from the first trimester, 5th week of pregnancy, and it nadirs in the second trimester of pregnancy, and it starts to increase near term again. So blood pressure also decreases during this period by 5 to 10 millimeter of mercury during the second trimester of pregnancy. So it decreases beginning from the first trimester of pregnancy. And hemoglobin, in the absence of hemoglobin and hematocrit, in the absence of iron supplementation, it tends to decrease beginning from the first trimester and nadiring with nadir at the third trimester of pregnancy. With iron supplementation, the curve will be reversed and there will be a 30% increase in hemoglobin and hematocrit. Otherwise, there is an increase in red blood cell mass, but because of a disproportionate increase in plasma volume, hematocrit and hemoglobin tends to get low. And the other important thing is turning patients from left lateral position to supine position decreases cardiac output by 25%. As you see, these are the red are left lateral position, the blue are supine position. Whenever patient assume supine position at any trimester, there will be a decrease in cardiac output. So see the heart rate, stroke volume, cardiac output decreases significantly whenever a patient assumes a supine position. So there will be a 25% decrease in cardiac output during supine position. And in fact, in 11% of pregnant ladies, there will be an acute occlusion of the inferior vena cava and the aorta, leading to a supine hypotensive syndrome of pregnancy or uterocaval syndrome. So there will be, as we see, a complete occlusion of the inferior vena cava, leading to a decrease in cardiac output owing to a decrease in venous return because of the compression of those vessels. And patient could develop during this time weakness, nausea, fatigue, dizziness, and patient may even develop syncope. So whenever you return them to lateral decubitus position, the symptoms will resolve. So patient could develop symptomatic hypotensive syndromes whenever they assume supine positions. And the other important thing is physiological changes during labor. As you all know, the physiologic changes during labor are abrupt because of pain related to labor, because of anxiety, and because of also uterine contractions. So just because of the physiologic changes and the increase in sympathetic output because of pain, exertion, anxiety, there will be a rapid increase in heart rate and blood pressure. This will lead to a 50% increase in cardiac output during early first stage of labor, a 25% increase during late first stage of labor, and a 50% increase in cardiac output during second stage of labor. Mind you, this is on top of the 30 to 50% increase in cardiac output because of those pregnancy-related physiologic changes. So it means the cardiac output almost doubles as compared to the pre-pregnancy level. And because of uterine contraction, again, up to 500 ml of, as you see, because of during uterine contraction, up to 500 ml of blood will be released to the systemic circulation. And so during that period, cardiac output totally could reach an increase of 75%. And so the maximum, as you see, it is seen during the second stage of labor. And during third stage of labor, as because of relief of the caval compression and also release of blood from the contracting uterus after the delivery, there will be 1 liter of blood returning to the systemic circulation. Hence, patients are at high risk of pulmonary edema immediately following delivery. As you see, during pregnancy, cardiac output and total blood volume tends to peak between 28 to 32 weeks of pregnancy, reaching 7.91 liters per minute. And during labor, this progressively increases and it reaches the highest level during the second stage of labor, and immediately within 1 hour post-delivery, cardiac output increases significantly. And when you see the hemodynamic changes post-delivery, as you see, heart rate, stroke volume tends to come down within, so heart rate and heart rate and stroke volume tends to come within 1 hour to pre-labor values, whereas some of the physiologic changes may take up to 6 months to resolve. So to summarize all, the most critical period in pregnancy for cardiac patients is in the first trimester between 12 weeks to 6 weeks, where the hemodynamic and cardiovascular adaptations starts to begin. And the area where these hemodynamic changes peak, this is between 28 and 32 weeks of pregnancy, and it is labor and delivery. So these 4 critical periods are important, where patients can develop heart failure, arrhythmia, and progressive deterioration of LV function. So we need to assess patients during this period, and we need to be vigilant to treat pulmonary edema and arrhythmias during this period. So these are percentage changes in the different hemodynamic parameters during each trimester of pregnancy and during labor, but most critical periods are 12 to 16 weeks of pregnancy, 28 to 32 weeks of pregnancy, labor, and delivery. So having said that, let's see some of the basic management of pregnant patients with cardiac disease. And it begins with assessment of a pregnant patient and assessment of fetus. And when you see the assessment, maternal assessments, it begins with history. Basically, we need to focus on symptoms and prior cardiac interventions. Physical examination, ECG and echo are important investigations. Of course, MRI may be needed in those valve diseases which have associated aortopathies like coarctation, bicuspid aortic valve malformation, and so on. Otherwise, the ECG, echo can suffice. And the other important thing is the pregnancy by itself may lead to symptoms in the absence of cardiac disease, which can mimic presence of heart disease, like decreased exercise capacity, dyspnea, palpitation, dizziness could be there, and there could be signs that can mimic cardiac disease in pregnant ladies, like loudest one, exaggerated splitting of S2. S3 could be heard, and then a systolic murmur, mid-systolic murmur could be heard at the left lower sternal border. But if it is greater than or equal to 3, grade 3 murmur, we need to exclude presence of cardiac disease. There could be continuous venous hum murmur because of mammary encephals, and there could be some ectopic beats. So these are all symptoms and signs which we can get in patients with normal pregnancy, and it may confuse with the existence of cardiovascular disease. And it's not only signs and symptoms. ECG could be abnormal with normal pregnancy in the absence of.
Dr. Sintayehu.
Yes.
Sorry, what happens to the pulse pressure?
Yes, the pulse pressure. Yes, the pulse pressure tends to get wide.
I thought the systolic would drop because of the vasodilatation. Yeah?
Yes, yes.
Okay, thank you.
So ECG could be, there could be axis deviation, left axis deviation on the ECG. SCTT changes could be present. Sinus tachycardia could be there, and echo could be almost all the parameters of echo. The dimensions will increase with exceptions of ejection fraction and pulmonary arterial systolic pressure, but the others, as you see, the diastolic dimension increases by some percentage in each categories, but all are within normal ranges. And there could be cardiomegaly within on chest X-ray. So on subsequent management, we need to have a preconceptional counseling for whenever possible. All women with cardiac disease should be offered with preconceptional counseling. And the presence of cardiac disease does not preclude pregnancy, but we have to know that it increases the risk for the mother and the fetus. And these risks vary with the functional capacity of the woman at pregnancy onset, and also the baseline risk of that specific cardiac disease. So prior to pregnancy, we need to counsel patients on both maternal and fetal risks, the morbidity and mortality. And if intervention is required, we need to communicate, and interventions has to be done prior to pregnancy. And we need to also emphasize on the need for hospital delivery and frequent follow-up. And if patient present for the first time with pregnancy and cardiac disease uncorrected, we need to discuss the risk and benefit. We need to decide with termination and continuation of pregnancies. We need to decide. I will have 1 or 2 slides on this. So to do that, we need to risk stratify patients, pregnant patients. A good risk stratification tool should incorporate a general risk factors which is relevant for all pregnant ladies. And we need to have also a lesion specific risk whenever it is available. And we need to have also patient specific data such as exercise tests. So this risk stratification will determine the frequency of clinical follow-up, will establish labor and delivery and postpartum planning. And this risk stratification is done with ECG, echo, and history and physical examination. So we have some classification, risk stratification tool, the CARPREG, the Zahara risk score, and the WHO score. As you all know, the CARPREG risk score is oldest and first maternal cardiac risk predicting tool, which consists of 10 cardiac risk predictors, 6 of whom are general risk factors, the others are lesion-specific risk factors. This is derived from a prospective observational cohort study from 2 major tertiary hospitals from Canada, involving 1,308 pregnancies, completed pregnancies, sorry. And so whenever risk score is, if you have a 0 and 1 point, the pregnancies with the percentage of pregnancies with maternal complication is 5%, with 2, 10, with 3, 15%. And if it is more than 4, it is 41% risk of maternal mortality. So this is a good risk stratifying tool because it contains on the study all patients with cardiac disease, but it is dominated by congenital heart disease. 63% of study participants on this study are having congenital heart diseases, It is only 28% of patients who have acquired heart disease, like rheumatic heart disease. So because of that, it has some limitations. The other is the Sahara risk stratification tool. The advantage of this Sahara risk score is it estimates maternal and offspring or fetal risks and neonatal risks, and this is again derived from a study which includes about 1,300 patients, but it is exclusively of congenital heart disease. So it is not applicable for the other group of patients. So whenever we counsel mother, we need to counsel the maternal risk, and we need to counsel also the fetal and neonatal risk of pregnancy. And we need to also emphasize on the risk of recurrence of congenital heart disease on the offspring. As you see on this table, the recurrence risk of congenital heart disease is very high, reaching 50% in those with Marfan syndrome, and in those with AV canal septal defect reaching to 50%. Mind you, this is also will increase in based on the chromosomal abnormalities the individual patient have. It may reach 50% even with AV canal defect in those with chromosome 22 deletions. So we need to emphasize also on recurrence risk of congenital heart disease. But the most accepted and applicable risk stratification tool we have is a modified WHO classification. It classifies patients into class 1, 2, 3, 4. And in those with class 4, this is where pregnancy is contraindicated. We need to avoid pregnancy because maternal mortality reached 25%, 25 to 50%. These are patients with significant pulmonary arterial hypertension, patients with severe ventricular dysfunction, patients with peripartial cardiomyopathy with residual LV dysfunction, Marfan syndrome with dilated aortic root, aortic coarctation of aorta, and severe mitral stenosis, be it symptomatic or asymptomatic. Severe aortic stenosis, only symptomatic, are class 4, where mortality is very high. We will see it, the valve diseases, one by one. So these are class 1, I will come later. So termination of pregnancy should be available for women with cardiac disease, but it has to be only in termination of pregnancy has to be considered only in those with very high risk groups I have mentioned, and it has to be done only in the first trimester of pregnancy. And even in the first trimester of pregnancy, it is better if it were done within 8 weeks. And suction and evacuation is a preferred method because medical termination of pregnancy also carries a risk, and especially if you use prostaglandins, the risk of maternal hypotension, especially with aortic stenosis, pulmonary hypertension, and in those patients with intracardiac shunts, the risk of hypotension is very high with prostaglandins, as is there. Even if you use local vaginal prostaglandins, there will be systemic absorption and there will be a risk of maternal hypotension. So these are the absolute indications for termination of pregnancy in the first trimester of pregnancy. Marfans with dilated aortic root greater than 45 millimeter, severe coarctation of aorta, Eisenmenger syndrome, significant pulmonary hypertension greater than 60 to 70% of systemic pressure. These are indications, absolute indications, but in any patient who develops class 3, class 4 symptoms in the first trimester of pregnancy, we may consider, because there will be progression during the subsequent pregnancy trimesters. Sorry. So the other management is antepartum management after pregnancy, medical, surgical, and obstetric management. It should be a multidisciplinary managing team. We need to limit strenuous exercise. We need to avoid excitement and strain. We need to have adequate rest. So there should be supplementation of irons and vitamins, low salt diet, and we need to avoid maternal hypotensions, and pneumococcal and influenza vaccination could be considered. We need to identify and treat infections, anemia, hypertension, arrhythmias early. And if they are in NEHA class 4, class 3, class 4, we need to admit and start treatment, and for both heart failure and the precipitating factors. And we may consider termination of pregnancy if it is early. Surgical management, cardiac related surgical management should not be considered during pregnancy, because open heart surgery is associated with high fetal risk. The maternal risk is similar as non-pregnant one, but fetal risk is very high. It may reach up to 30% with Marfan syndrome. It may reach 70% fetal loss. So we need to avoid it. If it is required, it has to be for valvuloplasty for both aortic and mitral. Valvuloplasty is what is preferred with valvular lesion, and even in that case, it has to be in the second trimester after 20 weeks of pregnancy. So obstetrics management involves time and mode of delivery, and management at around labor and also fetal scanning. During labor, as we have already said, induction of labor should be preserved only for obstetric indications. We need to wait for spontaneous onset of labor, and vaginal delivery is preferred in most patients. But there should be a continuous lumbar epidural anesthesia and pain control. But whenever we use continuous epidural anesthesia, we need to look for maternal hypotension, as I said, in aortic stenosis, intracardiac shunt, and pulmonary hypertension. And if there is a need for induction of labor, we need to use only oxytocin. And whenever we use oxytocin, we have to use higher concentration with restricted fluid to avoid fluid overload. If possible, we may use mechanical methods with Foley installation, especially in congenital heart disease, to avoid complications. And cesarean sections are indicated only if labor starts in an anticoagulated, in a patient who is on oral anticoagulant. Before switching patients, if labor starts, we need to use cesarean section because there is a risk of intracranial fetal hemorrhage. And the other is Marfan's to avoid progression and aortic dissection. And patients with aortic dissection, severe symptomatic aortic stenosis, Eisenmanger's, in this group of patients, cesarean section has to be done. Otherwise, we should not advise cesarean section routinely, because similar to vaginal delivery, cesarean section is associated with a significant hemodynamic fluctuation associated with intubation, extubation, the anesthesia, analgesia, and so on. So spontaneous vaginal delivery is a preferred one. And in those with patients who are on anticoagulant with prosthetic valves, we need to, for elective delivery, we need to shift oral anticoagulants into lower molecular weight heparin and unfractionated heparin at 36 weeks of pregnancy, and we need to stop that 4 to 6 hours. I will discuss it later. But if there is an emergency delivery, either because of fetal distress, obstetric indications in general, or spontaneous onset of labor while patient is on anticoagulant, if it is heparins, we need to reverse it with protamine. If it is patient is on oral anticoagulant, it has to be a C-section, and we need to give fresh frozen plasma and oral vitamin K, and we need to lower INR below to do cesarean sections. The other important thing is management of labor. There should be intensive hemodynamic monitoring. Patient, we need to follow pulse, blood pressure, and oxygen saturation has to be kept, and oxygen supplementation may be required. Patient has to be on left lateral position to avoid maternal hypotension, and there should be a careful attention to volume status, and fluid supplement should not pass less 75 ml per hour, and IV furosemide can be given intermittently during labor, as especially in the second stage of labor, as cardiac output and blood volume will increase significantly, and postpartum periods. We need to treat arrhythmias with if it occurs with digitalis and beta blockers, and epidural anesthesia should be used, and we need to shorten the second stage of labor with episiotomy, forceps, and or vacuum, and we need to avoid. We need to tell patients to avoid pushing down or exertion during the second stage of labor, as it decreases venous return and decreases cardiac output. So we need to avoid pushing down or exertion during the second stage of labor. During postpartum care, we need to be energetic to avoid postpartum hemorrhage, and we need to avoid bolus of ergometrin, as it results in arrhythmia and complications. So there should be a slow IV oxytocin infusion. It has to be less than 2 units per minute. And ergometrin has a 10% risk of vasoconstriction, and it results in high blood pressure and result in heart failure in the postpartum period. So we need to avoid it. And we need to monitor patients for 24 to 72 hours for possible pulmonary edema in the postpartum period. Once patient has delivered, we need to offer contraceptions, and the barrier methods are unreliable. We need with a failure rate of up to 28%. So we need to avoid barrier methods for this kind of patients. Oral contraceptive pills are contraindicated because of increased thromboembolic events. So the barrier methods are, the permanent or methods or long-acting intrauterine devices are the preferred one. We need to go with that, especially the long-acting, slow-releasing Mirena intrauterine devices have the highest efficacy. If they have to use PO, progesterone-only pills are the better one. So just to look some slides on valvular heart disease and mechanical valves, as these are the common valve diseases, cardiac diseases we have in pregnancy. And as you see, the most common valvular heart disease in pregnancy is mitral stenosis, followed by mitral regurgitation and AR. Generally, stenotic valvular lesions are less well tolerated than regurgitant lesions, especially stenotic lesions which are severe and left-sided are less tolerable in pregnancy. And the risk of complications associated with valvular heart disease varies with the type and severity of the underlying cardiac disease. Just this is a patient we have managed 2 years back in our hospital. This is a 37 years old woman from Hawassa with no known medical heart disease in the past. With she has 2 uneventful pregnancies in 2005 and 2010 European calendar, Gregorian calendar. So and we were consulted at the time during the 4th month of pregnancy, that is 16 weeks. She claims to be asymptomatic, but she has diastolic, grade 3 diastolic murmur, opening snap, no sign of heart failure. BP is normal. She's in sinus rhythm, and echo showed, as you see, valve area is 0.7 centimeter square. Mean gradient is 16 millimeter of mercury. The valve score is okay, 7. It is favorable. MR is mild. Pulmonary pressure systolic is 45 to 50 at rest. And what do you think is the therapeutic option for this patient? Should we terminate the pregnancy? Should we do straight away percutaneous mitral commissurotomy? Should we start her on beta blockers and follow? Should we start her on diuretics? Or that is it possible to follow her without treatment? These are the different options we have for management of patients with mitral stenosis. But as you see, patient has severe mitral stenosis, but she is asymptomatic, class 1. So termination of pregnancy is debatable. And she tolerated the pregnancy very well till 16 weeks of pregnancy. So there is no indication to do valvotomy or surgery. So the best option is to begin beta blockers. So beta blockers has to be the first line treatment for patients with mitral stenosis. By decreasing the, as you know, patients with mitral stenosis, they are unable to tolerate pregnancy because they are unable to tolerate the increased cardiac output and the increased heart rate. The increased heart rate will decrease the diastolic filling time, and so it increases LA pressure. It means it increases risk of atrial fibrillation and pulmonary hypertension. So the prophylactic use of beta blockers is indicated for those with symptoms and pulmonary hypertension. So the good choice to begin with is initiation of beta blockers. So it shows it started with in beta blocker metoprolol, and despite the use of beta blocker with adequate heart rate control, as you see 70, patient continues to have NEA class 3 dyspnea beginning at week 24, and ECG sinus heart rate is 70. Echo you repeated, valve area is almost the same, 0.8, mild MR, but mean gradient has increased. Normally, with the increased volume will result in increased transvalvular mean gradient in pregnancy normally, but it significantly increased from 60 to 20. Pulmonary pressure increased to 65 despite a beta blocker. And you added the second step to manage this patient is adding furosemide, because if patient develops heart failure despite adequate heart rate control, you need to add furosemide. We added normal fetal control. What therapeutic options would you consider? Should we do valvotomy, or should you go with surgery, open or closed commissurotomy? Or should we add further the diuretic? Or should we induce patient or advise patient for early delivery? The best option here is valvotomy, because patient has severe symptomatic MS despite medical therapy. If somebody is class 3, class 4 symptoms despite furosemide and beta blocker, we need to go for valvotomy because we have to do it in the second trimester between 20 and 28 weeks of pregnancy, because this group of patients are at high risk of fetal and maternal complications during the third trimester of pregnancy. So because of that, we need to do it as soon as possible. And in this patient, valve score is 7, mild MR, no thrombus, so anatomical condition is suitable. And the pregnancy term is greater than 20 weeks, 24. So we need to do it as soon as possible. So valvotomy was done for this patient at 26 weeks of pregnancy. TA was done pre-procedure, no thrombus. So with a stepwise Inouye balloon technique under echo monitoring, valvotomy was done. And as you see, both commissures have splitted, and there is no MR, and valve area has increased to 1.8, mean gradient has dropped from 20 to 7. Pulmonary pressure has dropped from 65 to 40, as you see. And vaginal delivery was attained at 39 weeks of pregnancy with epidural anesthesia here at black line, and there was no dyspnea at birth. She delivered a healthy newborn. So in general, mild asymptomatic mitral valve disease is tolerated in pregnancy very well. And rates of pregnancy, rates of heart failure was highest in severe MS, 49%, and it is 31% in moderate mitral stenosis. And the rate of complication is similar whether you have severe mitral stenosis alone or combined with mitral regurgitation. There is no difference. So severe mitral stenosis is an independent adverse predictor in patients with MS and pregnancy. And 60% of the women will develop their first pulmonary edema at 30 weeks of pregnancy. So whenever we have pregnant mitral stenosis patients, we need to look at between 28 32 weeks at labor and at delivery. These are the critical period for MS patients. And as you all know, because of an increasing 50% increase in coagulation factors during pregnancy and an increase in platelet adhesiveness during pregnancy, pregnancy is associated with hypercoagulability. So in those patients with atrial fibrillation, we need to anticoagulate patients well, as the risk of thromboembolism is very high. And maternal mortality for severe MS is 3%, for moderate MS is 1%. But if severe MS patients have NEHA class 3, class 4 symptoms, the mortality will increase up to 31%. So we need to do interventions for those group of patients in the second trimester of pregnancy. And fetal complication is also high. Prematurity can reach up to 30%. IUGR and stillbirth is very high. So unlike severe aortic stenosis, patients with severe mitral stenosis with a valve area of less than 1.5, even if their functional status is good at the before onset of pregnancy, like even if they are NEHA class 1, class 2 before pregnancy, they can decompensate subsequently. The risk is very high, as you see. They usually don't tolerate pregnancy, even if they are NEHA class 1. Whereas patients with aortic stenosis, if they are asymptomatic at onset of pregnancy, they usually tolerate pregnancy very well. So, as I have said, beta blocker for symptoms and then pulmonary hypertension patients, diuretics if they have persistent congestive symptoms, interventions for those who continue to be symptomatic and they have severe pulmonary hypertension despite medical therapy. But the European Society of Cardiology also recommend prophylactic valvotomy or valve repair for those patients who have a mitral valve area less than 1 before pregnancy. American Heart Association also recommends valvotomy before pregnancy for symptomatic patients with valve area less than 1.5. We prefer valvotomy over surgery because maternal complication is low, less than 2% maternal mortality. Fetal outcomes is excellent, which is with a mortality rate of less than 4%, because fetal mortality can reach a high level in those who has undergone surgery. So this I have already said. I will not with mechanical valves. Just I will have 3-4 slides. We need to think twice before deciding on mechanical valve replacement for childbearing age females, because as you see, we have different valve options, mechanical and biologic valves. And mechanical valves are associated with a higher thromboembolic and hemorrhagic risk and a higher fetal complications as compared to biologic valves. And biologic valves have, as you see, the risk of reoperation is very high. And also valve failure within 10 to 15 years is very high, especially in those with heterograft. Though mechanical valves in those less than 53 years of age, in those less than 53 years of age has a mortality advantage. It is associated again with a higher complication during pregnancy. These are studies then comparing mechanical and biostatic valves during pregnancy. This is a systemic analysis of all the studies done between 1985 to 2015. And as you see, the mechanical groups have a higher thrombotic and hemorrhagic risk and a higher miscarriage risk, but maternal mortality is similar. And again, mechanical valves as compared to no prosthetic valves is associated with a higher maternal mortality, and the use of warfarin is associated with higher risk. When you see outcome with mechanical valves with different anticoagulation strategies, this is very important. As you see it, maternal mortality, and when you see maternal mortality and valve thrombosis, as you see, if you continue warfarin throughout pregnancy, the risk of maternal mortality is 2%. And if you continue warfarin throughout pregnancy, the risk of valve thrombosis is 3.9%. If you continue unfractionated heparin throughout pregnancy, the risk of maternal mortality is 50%. So continuing unfractionated heparin throughout pregnancy is not recommended. It is associated with a 15% maternal mortality, a 33% thromboembolic phenomena. And with sequential therapy, it means giving unfractionated heparin between the 6 and 12 weeks of pregnancy and after 36 weeks of pregnancy. As you see, the risk of maternal mortality is again 4%, with a valve thrombosis risk of 9.2%. So the best, if possible, is to continue oral anticoagulants throughout pregnancy, which is associated with low maternal mortality, low valve thrombosis. The big problem is oral anticoagulant warfarin can cause embryopathy and fetal loss in the first trimester of pregnancy. It can reach up to 10%. And so switching to unfractionated heparin between 6-12 weeks of pregnancy can decrease this risk. The good thing is if you are able to maintain the INR bit in the therapeutic range with a warfarin dose less than 5 milligram per day, the risk of embryopathy is low, 2.6%, but it can reach to 8% if you go more than 5 milligram per day, 5 milligram per day. So we need to continue warfarin if the dose the dose they require is less than 5 milligram per day. We need to continue warfarin throughout pregnancy with monitoring of INR until 36 weeks of pregnancy, and then switch to unfractionated and stop it 4 to 6 hours before delivery and restart it after 4 to 6 hours of delivery. If they require high dose, we need to switch them and put them on unfractionated heparin or lower molecular weight heparin twice daily, but we need to monitor APTT, and also for patients who are on low molecular weight heparin, we need to monitor anti-factor 10. If you don't monitor anti-factor 10, we need to better avoid unfractionated heparin and go with APTT. But we need to communicate the high risk of maternal mortality with unfractionated heparin, the 50%, and the high thromboembolic event, that is 33% with unfractionated heparin. To combat that, the Americans, they add aspirin during the second. So if you go for whether with warfarin less than 5 milligram or unfractionated heparin, addition of aspirin during second trimester to decrease the increased thromboembolic event is recommended. So these are class of drugs. I think you will revise it, their risk and pregnancy. Digitalis beta blockers like metoprolol and adenosine for arrhythmia management are safe, and we can use those, but amiodarone, atenolol, and others are class D. Unless we are forced, we should not be use those drugs. Thank you. If you have any questions, sorry for taking finishing late. Sorry. Any question? If you have if you don't have any questions, sorry. Okay.
Yeah. It's an excellent session, Sintayehu. Thank you very much. It's very informative, and it will help our residents and fellows to improve cardiovascular care during pregnancy. It was really an excellent presentation. Thank you.
So there are comments in the chat box, Doctor. Have you seen them? There is no questions. They are all appreciated.
Okay.
From Dr.
Okay, thank you.
and Dr. Abdul Razak.
Thank you. Thank you.
So if there are no questions, I think we can end up our morning session. Thank you, Doctor, for the excellent and very informative lecture.